Today we're going to talk about the auditory system. It's just beautiful, but it's very tiny and hard to see. But I want to dwell on it because many of the problems with the auditory system have to do with the external conductive mechanism or the sensory neural hair cells and nerve, and not with central connections. So we'll start with a little more detail here. I have a beautiful dissected and isolated and prepared and painted temporal bone. This temporal bone is from the left side of the skull, so it would fit in my ear approximately like this. My external auditory meatus would correspond to this area here. And let's now bring it down. Here's the zygomatic arch coming forward. And this is all the squamous part of the temporal bone. I'm going to put it down here on the table. And now we're going to look at the details on the inside that have been prepared for us. What we can see is the imprint of the middle meningeal artery that really runs in the dura, but it makes a groove here in the bone, very important for lacerations of the temporal bone. We can see the blue vein, which is draining blood from the brain into the internal jugular vein. We can see the internal carotid artery, which is very important with its relationship. And now if I tip this, you can see the teeny weeny little cochlea. The cochlea, which is 2.5 snail turns, looks like a seashell, and you can see one of the painted canals of the semicircular canals here in green. And back in here we have the mastoid process, and if we open it up we can see the air cells that are inside the mastoid. This is the mastoid process here, where you put your tuning fork to test for conduction, and here are cross sections of the facial nerve, which travels through the internal auditory meatus and exits the brain, separate from the auditory system, but it's traveling through there and is often involved with auditory disease. And here is one of the semicircular canals. And nicely shown here is the inside of the eardrum. The external auditory meatus, which is here, if you look through it with your otoscope, you will see the other side of the tympanic membrane. Here, two of the ossicles that vibrate with sound waves are shown here, the incus and the malleus. And now let's go to a larger model where we can look at these things in more detail. So this temporal bone model is from the right ear, the opposite from the last one we were looking at. And here we have the external part of the ear, which is gathering sound waves and funneling them into the external auditory meatus. A word of warning: when you're testing facial sensation, avoid testing the skin around the ear because it's innervated by several cranial nerves, 5, 7, 9, and 10. So unless you're an expert on embryology, be a little careful and remember that more than one cranial nerve innervates this area. Now we can look into the external auditory meatus here, and if we were to have enough light, we would see that at the end of the tunnel there is a membrane, the tympanic membrane, and that is what you look at with your otoscope. So now let's look at an even larger model, and we're going to take it apart and we're going to go into the middle ear. So here's our even bigger, better model. Mastoid process, right side of the head, and now let's rotate it and look at the inside. So now this end is anterior toward the nose, and this end is posterior toward the occipital region. And what I want to do now is, this is going to be the inner ear, but we want to start with the middle ear. So I'm going to remove this part with the inner ear. Now we have a really good view of the tympanic membrane here as seen from the middle ear. And we can see the 3 ossicles, the 3 bones, the malleus, the incus, and the stapes, that are attached here for amplifying the sound wave that is coming from the external ear. And the stapes here, this blue foot plate, is compressing a membrane called the oval window. And this is the place where the air conduction of the wave is transferred into a waterborne wave of sound, because I'm going to show you in a moment the cochlea and the area where the fluid compartments will move the sound wave to stimulate different parts of the cochlear and different hair cells. And of interest is this white nerve coming across here. This is called the chorda tympani. It happens to be a branch of the seventh nerve, a branch that is carrying taste and going over to the tongue. It's very incidental, but it's very obvious. And the other thing that I want you to notice is the eustachian tube. This is the tube that connects the middle ear with the back of the pharynx. And so this is how you equalize the air pressure between the oral cavity and the middle ear. This channel can easily be swollen and occluded in any kind of inflammation in the oral pharyngeal cavity. Infections can then build up in the middle ear. This condition is called otitis media, and fluid can accumulate and press against the tympanic membrane so that the tympanic membrane can bulge out and can be viewed with your otoscope from an external auditory canal. Also, the relationship to the mastoid air cells means that the infection could also move into the bone and become even more serious. So, disease of the middle ear has to do with either the bones not conducting or moving properly, or fluid or infection are the most common problems when we deal with middle ear disease. And when we test for hearing, when we say there is a conductive loss of hearing, we're talking about either the bones are not working right, or there is a problem in the external auditory canal and the sound waves are not getting through. So now let's look at the cochlea. The inner ear is sometimes called the labyrinth. I think that's an appropriate name for it. And let's just remove it. It sits in a bony cavity. So there are two parts to this labyrinth, an outer bony labyrinth, and then inside it a membranous labyrinth, suspended with fluid outside and fluid inside. So now we are looking at the membranous labyrinth. And if I rotate it like this, you can see these two pink spots, the oval window and the round window. The oval window is where the stapes footplate was, and so it's banging against this membranous window, the oval window, and setting up sound waves in the fluid in the perilymph canal that's inside here that we'll look at. And the round window up here is the place where the sound wave going through the fluid is relieved. So pressure at this end and relief of pressure at that end. Perhaps of interest is the fact that through this round window is where an electrode is placed when a cochlear implant is performed in order to stimulate artificially the nerve that remains after hair cell loss. Now, let's go and see how this fluid affects the cochlea itself. So now I'm taking apart and we're looking at a cross-section of the cochlea. And we're going to look at this in more detail in a diagram, but here we have the three fluid-filled spaces. The upper one is where the sound wave is coming, and it's vibrating this membrane here that's called the vestibular membrane, and it goes this sound wave travels all the way up to the top point here, called the helicotrema, and then it goes down. It's kind of like an amusement park here, and you go down the slide, and then the sound wave is traveling in this compartment down here. And this is the one that's connected to the round window. So the sound wave set up by the stapes goes up this canal or channel and down this one. And in here, and this is filled with perilymph, in this channel here, called the scala media, this is where the hair cells and the receptors are that perform the transduction. High potassium, like in your CSF, is in this space. And on this membrane, called the basilar membrane, sit little hair cells. And the hair cells are moved, their cilia, their stereocilia as they're called, are moved and open channels through which potassium flows and ion currents are set up that begin the conversion of a mechanical wave into an electrical signal. Now let's look at a diagram of these hair cells in detail. So here we have a very nice diagram of the basilar membrane with the hair cells sitting on top of it. It's these inner hair cells that are most important because they are the ones that have most of the sensory endings that are carrying the information to the brain. The outer hair cells are thought to have more to do not with sound transduction, but with the tension on the basilar membrane. So it's these 15,000 inner hair cells that we really want to protect from loud sounds and from toxic elements, particularly antibiotics. On top of the hair cells sits another membrane called the tectorial membrane, and it touches the stereocilia of the hair cells. And when it vibrates, because it is in the endolymph and the pressure wave causes vibration of this membrane, then the stereocilia are bent, and this deformation of the membrane causes potassium to flow. And it is amplified by a similar movement of the basilar membrane, which also puts pressure on the stereocilia, causing them. So there are two mechanisms for the deformation of the stereocilia, the tectorial membrane and the basilar membrane. So depending on where you sit on the basilar membrane, the top or the bottom, the high tones, the low tones, will determine the kind of labeled line you are going into the central nervous system. So now let's take this information into the brain by looking at the gross specimen. I've selected some gross specimens that I think will show you the salient features of the auditory pathway to the cerebral cortex. And let's begin with the skull here. And I have set a axial section through the cerebellum and medulla here for you to look at. And I want you to notice that the 7th and 8th cranial nerves, the facial and cochlear vestibular, are coming in or going out, depending on if you're sensory or motor, through this hole in the skull called the internal auditory meatus. So remember, 7 and 8 go together. So problems with the auditory nerve often are accompanied by problems of facial paralysis. And let's move over to the brain dissections. Here we have the medulla, and we have the pons, and just a beginning of the midbrain, the end of the cerebral peduncles. And the 7th and 8th nerve come in on the lateral side, right at the level of the junction between the medulla and the pons. The 7th nerve is more medial, and the 8th nerve is more lateral. And you can even sometimes see a groove in the 8th nerve. One part is the vestibular part, and the other is the cochlear part, the vestibulocochlear nerve. Down here, you can see cranial nerves 9 and 10, and this area here that I'm outlining is the cerebellopontine angle. And in this area, there is a predilection for tumors to grow on the vestibular or acoustic nerve. These are Schwann cell tumors, schwannomas, and sometimes they're called neuromas. So now let's move on to a cross-section. So here we have our two cerebellar hemispheres. This space here is the fourth ventricle. This is the vermis of the cerebellum hanging down into it. And this is right at the junction between the pons, which is off here to the side, and the medulla. So this is at the rostral part of the medulla. Here are pyramids, our olive, our inferior cerebellar peduncle. And here we have our seventh and eighth nerves coming in on the side here. And they end, the auditory nerve ends right here, along here, in a nucleus called the dorsal or ventral cochlear nuclei. There are actually three nuclei. So all of these auditory fibers coming from the auditory nerve end in these cochlear nuclei. And from here, now, the information ascends but makes multiple crossings. And this is an important point. Because of the multiple crossings, unilateral hearing loss either has to be the hair cells, the nerve, or these cochlear nuclei right here if it is of the sensory neural type. In other words, it either has to be the hair cells or these axons, because after this, information is crossed and you do not get a unilateral hearing loss. So now we're going to proceed up the brainstem, and now we're at the level of the pons. We still have the fourth ventricle. Here's your typical crisscrossing fibers of the pons. That's where the basilar artery would be. And we have on this specimen, obviously different from the last, we still have a bit of the eighth and seventh nerves remaining. And we can see the deep cerebellar nuclei and the cerebellar hemispheres out to the side. And our fibers are traveling on either side. There's some important connections made for sound localization in the pons, in the superior olivary nuclei, that help us localize sound out in space. So we can tell if sound's coming from the right or the left, and we can tell within a very few degrees. Now, as we continue farther up the brainstem, I'm going to split the cerebellum here so you can look down into the fourth ventricle. I've split the vermis here. So we're looking into the fourth ventricle, and at the top of the fourth ventricle, the ventricle ends and becomes the aqueduct, and at this point we have two bumps, the colliculi, the superior and the inferior colliculi, and the auditory system relays in the inferior colliculus. This bump right here, this irregular cut here shows the superior. They're involved with vision, but the inferior colliculi are what we say helped us orient. When your head moves with a quick sound to one side or the other, you are not only localizing it, but you are responding in an almost reflexive way to a sound, whether it be threatening or just environmental surprise. That is the inferior colliculus. Again, there are multiple crossings in the auditory pathway as it ascends. From the inferior colliculus, we're going to move up to the thalamus. So this is a nice picture that shows you the colliculus and the aqueduct. So this piece here is midbrain. And then as I tip this, I hope you can see here is our temporal lobe on either side. It's a little bit broken on this side. And there are a band of fibers that come from the colliculus over to a nucleus on the side and down in the back of the thalamus called the medial geniculate nucleus. And it's hard to identify, but like all other sensory systems except the olfactory, audition has a relay nucleus in the thalamus, and that is the medial geniculate. And I'll show it to you now in an axial section. Here is an axial section. This is the occipital lobe, and this is the frontal lobe. Here is a bit of the cerebellum, and this is the beginning of the thalamo mesencephalic junction. So this is the end of the superior colliculus, and out here is our thalamic nucleus, the medial geniculate nucleus, right next to the lateral geniculate, which is associated with the visual system. So medial music, lateral light. Medial geniculate is for the relay nucleus for sound, and then this tonotopically organized label lines goes through this back part of the internal capsule and out here and over to the temporal lobe, because we have a primary auditory cortex over here in the temporal lobe called the transverse temporal gyrus. And now we'll look at that in a whole brain. So here I have a left hemisphere to be oriented. This is the frontal lobe, parietal lobe, occipital lobe, and temporal lobe. And so primary, or the main auditory cortex, is in the temporal lobe, and it's buried in this lateral fissure. And there are two gyri called the transverse temporal gyri buried deep in there, and I'm going to pull them apart. In this lateral fissure, you can see two transverse temporal gyrus. I'm going to put my finger over it and remove it. And that is primary auditory cortex. Deep in the lateral fissure, you can see multiple branches of the middle cerebral artery, most important branches. And you can also see beneath them some cortex. That is insular cortex. That is the insula. And now as I close this, I want to point out to you that there is, again, a tonotopic organization along those transverse temporal gyri, with high tones being in one area and low tones in another. And if you were to electrically stimulate this cortex in an unanesthetized patient, they would report to you certain sounds. More important, perhaps, is this superior temporal gyrus. The temporal lobe has three gyri that you can see: the superior, the middle, and the inferior. And the back part, the back third or half of this superior temporal gyrus, is called association cortex, and it's very much involved with the interpretation of sounds. This is where we put the sounds together and make language. And damage to this area results in people having no hearing loss, but not understanding, or at least in part not understanding, what they are hearing, or being able to repeat things. And so we have a language disturbance called aphasia, and this area was described by a Dr. Wernicke, and so often this is referred to as Wernicke's area and extends back and around in this area a little bit, around the end here of the lateral fissure. So Wernicke's area in the left hemisphere, which is dominant in 97% of people, language is lateralized to the left hemisphere, even if you're left-handed, because 10% of the people are left-handed, but only about 3% of people have language lateralized to the right hemisphere. So we want to summarize in saying that primary sensory cortex is deep in the lateral fissure, surrounded by the superior temporal gyrus, which is important for the interpretation of language. And with that, let's talk about how we come to test hearing loss. So the first test we do is the Weber test by putting the base of the tuning fork, when it's vibrating, in the center of my head and finding out if I hear it more in one ear or the other, or equally. Normal should be equal in both ears. If I don't hear it in one ear, then I have either a conductive or sensory neural loss. It doesn't tell me which ear, and it doesn't tell me which loss. So I have to do the second test, which is called the Rinne test. For that, you have to put the tuning fork on the mastoid process, which I'm going to do now, and ask the patient to tell you when they no longer hear it. And when they no longer hear it, then you take it and you put it just in front of their ear, and normal person should continue to hear it for about twice as long as they heard it through the bone. And that is normal. with a sensory neural loss, it will be shortened. And with a conductive loss, there will be no air conduction because the vibration of the tympanic membrane is not getting through to the oval window to set up a sound wave traveling in the cochlear fluid. So let's look at a neurologist doing this on a patient who has a hearing loss, and see if you can tell whether the boy has a sensory neural loss or a conductive loss.
Can you hear that there? Hear it over here? Harder to hear over there? Okay. All right. Can you feel it in the middle or to one side? Feel it over there? Okay. All right. Can you feel it back here? Okay. Tell me when it stops.
It stopped.
Can you still hear it? Okay. Tell me when it stops over here.
It stopped.
Can you hear it? No. Oh.
And so from that you can see that this young boy has a conductive hearing loss. So now I want to show you an axial radiograph through the pons. So let's just orient ourselves. Here is our pons, and here we have the fourth ventricle with a bit of the vermis of the cerebellum, and here we have cerebellum on either side. And now what I want to show you is the seventh and eighth nerve along with the semicircular canals and the cochlea. So let's look here. Here we have the cerebellum with the vermis, the fourth ventricle, the pons, and then here you see both the cochlea and the semicircular canals, cochlea and semicircular canals on each side, along with the bright CSF in the subarachnoid space and the basilar artery. And notice you can see two dark lines representing both the facial and vestibulocochlear nerves coming in to the junction between the medulla and the pons. So this is normal. The cochlea is in front of the semicircular canals. Here is the cochlea. You can almost imagine 2.5 turns. Now the next axial section I'm going to show you is with a tumor in the cerebellopontine angle. Again, we have the same relationship. We have the pons, the fourth ventricle. This is different. The CSF is not bright in this one. And you can see the tumor right here in the cerebellopontine angle. This is the angle, and it's actually invading into that internal auditory meatus. So this patient would have had not only a sensory neural hearing loss, but would have also had signs and symptoms of facial paralysis and most likely problems with disequilibrium and balance and gait because of the vestibular part of the nerve. As a matter of fact, these acoustic schwannomas, as they are called, often occur more frequently on the vestibular part of the vestibuloacoustic nerve, or the cochlear vestibular nerve, however you want to call it. Now we'll look next at this same tumor in a coronal section. Now to orient you, this is a coronal section, so we have our lateral ventricles, our third ventricle, this would be the thalamus. Here is the temporal lobe on one side and the other, and here would be the midbrain and the pons bulging here and the medulla. And here is our tumor in the cerebellopontine angle, and here would be the part that is growing into the internal auditory meatus. And so this is a left acoustic neuroma with a sensory neural hearing loss on the left side. Recall in radiographs, this side is always the left side, as if you were standing and facing the patient. And so this is the take-home message that the auditory system is fascinating. Most of the problems are peripheral or have to do with the cerebellopontine angle, because after that, the crossings of the auditory system all the way to the cortex make it a difficult system to use for neurologic localization.